Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at St. Joseph's Candelier Health System for hosting today's session, Thyroid Disease with Dr. Merri Pendergrass. Dr. Pendergrass is professor of medicine at the University of Arizona in Tucson. She is currently clinical chief of the Endocrinology Division and director of the Endocrinology Fellowship Program. Prior to joining UA, she was on the faculty and established multiple professional diabetes programs at Harvard and Tulane medical schools. So, Dr. Pendergrass, when you're ready, please begin.
Okay, good afternoon, everybody. And I would, thanks for being here to listen to around an hour of discussion about thyroid disease. I'll warn you ahead of time that there may be a cattail walk by, so if you see me jump up for a minute, that's me throwing the cat out. So I have no disclosures, and here's some information about the accreditation and the objectives. And so let's start in with an overview. When I talk about thyroid disease, I'm talking about kind of two different things. Now, there's a lot of overlap in these things when we're addressing patients with thyroid conditions, but there's thyroid nodules and there's problems with thyroid function. And these are kind of two separate but related things. Let's start out by a discussion of thyroid function disorders. So this slide just shows that there's a whole spectrum of thyroid dysfunction. On the edges of the spectrum, we've got severe hypothyroidism, which is myxedema coma, and severe thyroid storm, which is uncontrolled hyperthyroidism. People draw the lines about what is technically coma or storm, but it doesn't really matter. It's just severe disease. Usually, once someone has mental status changes, it sort of falls into this category of storm or coma. But most of what we see are these conditions in between. So let's start with the case. Here's a 30-year-old woman. She has 10 months of increasing fatigue, weakness, constipation, dry skin, cold intolerance, heavy periods. And so, the question is, what do you do next? Now, just looking at her signs and symptoms, she sounds like she's got hypothyroidism. Everything she has is classic for hypothyroidism. The weakness, the dry skin, heavy menstrual periods, classic symptoms of hypothyroidism, and it's been going on for 10 months, which is important. So as you're all kind of thinking about, what test you'd like to get, whether you want to get a TSH or you want to get a TSH plus some other labs, I'll tell you that what I would do is I would just get the TSH. She's got classic symptoms and this is too easy. So we get her TSH and it's 25. So there you have it. We're done. You have a diagnosis pretty much, and you know what your next step clinically is going to be. Her diagnosis is primary hypothyroidism. That means there's something wrong with the thyroid. That makes it primary. And the etiology, well, just playing the odds, this is Hashimoto's. Now there's some other conditions that it could be, and we'll talk about those on the next slide, but just playing the odds, if it, looks like a duck and walks like a duck and talks like a duck, this is classic Hashimoto's hypothyroidism. This is the kind of thyroid dysfunction you see commonly in primary care. We screen asymptomatic people for it sometimes because it's so common. Anyway, so it's probably Hashimoto's. It's definitely primary hypothyroidism. And this slide just sort of reviews, the potential causes of hypothyroidism. And when I make this diagnosis, I certainly run through what may be the causes. Usually, like I say, it's this autoimmune disease, Hashimoto's, but it could be the thyroiditis. We'll talk more about that in a few slides, but in this person's case, I don't think it's thyroiditis because thyroiditis is transient. You have a hyperthyroid phase followed by a hypothyroid phase, and then it normalizes. Classically happens after a virus or after delivery of a baby, but it's short-lived. And our patient had her symptoms for 10 months. So if you've got it for 10 months, it's not thyroiditis because each phase of thyroid function in thyroiditis is 2 or 3 months at the most. And then there's all these other things that it could be, and so they certainly crossed my mind, and you can pretty much figure this out based on a history. And it's nice to think about it because it can tell you a little bit about prognosis, but in general, primary hypothyroidism is treated pretty much the same, with the exception of a thyroiditis and maybe the drug associated with lithium and amiodarone, which also can resolve eventually on its own as well. So I go through these, see what I've got. Just remember, you could also have a secondary hypothyroidism, and that's what happens when the thyroid's fine, but there's something wrong with the pituitary or the hypothalamus. So once you've made a diagnosis of primary hypothyroidism, high TSH, typical symptoms, likely Hashimoto's, what's your next step? Well, your next step is just to start levothyroxine, because none of these other things are going to change management. The free T4 will be low, the free T3 probably will be low, and antibodies, are likely to be present, but it doesn't change anything. You're still going to treat them. So these things are considered not cost conscious because it doesn't change management. And you really don't want to get a thyroid ultrasound. And patients are referred to us all the time because they got an ultrasound after a diagnosis of hypothyroidism, and you don't want to do that. This slide just shows, some recommendations from that old Choosing Wisely program. You might remember that. This was American College of Physicians program where they asked specialties to list some things that are commonly done in their specialty that shouldn't be done. And on the list was, do not routinely order a thyroid ultrasound in patients with abnormal thyroid function tests if there's not a palpable abnormality of the gland. You should only get an ultrasound if you palpate an abnormality or you see an abnormality on some other kind of imaging study, like a CT scan, and it's an incidentaloma. You weren't looking for it, but you saw it. That's when you get an ultrasound. But the reason you shouldn't get an ultrasound with hypothyroidism is because thyroid nodules are common. And, I always joke when we teach our fellows how to do thyroid ultrasounds, I always joke that I wouldn't let anyone go near my neck with an ultrasound machine because I don't want them to find an incidentaloma that doesn't mean anything and that can just lead to years of surveillance that it's just, it's not helpful, and it causes a lot of problems for patients if they find an incidentaloma and you have to do something with it. So no ultrasounds, just treat the woman for hypothyroidism. Now here's another case. Here's a 60-year-old man. He's got also classic symptoms of hypothyroidism. He's got a whole year of fatigue, weakness, cold intolerance, constipation, dry skin, and bradycardia, and he looks like that. He looks severely hypothyroid, but his TSH is normal. Could he still have hypothyroidism? Well, of course he could. Remember, primary hypothyroidism was what our first patient had. Her thyroid isn't working right, so her free T4 is low, and her TSH compensates appropriately. Her pituitary was working, so it compensates appropriately, and there's a high TSH. But in a secondary hypothyroidism, the TSH can be low or it could be normal. And the terms that endocrinologists use a lot is it's inappropriately normal. It's not elevated. And so the free T4 is low, but that's because pituitary is not working. So secondary hypothyroidism happens. So just as a reminder, you cannot exclude a diagnosis of hypothyroidism in a person with classic symptoms based on a TSH. A TSH is a great lab to get when you're screening asymptomatic people. And when you're also, if you're screening someone with classic symptoms like our young woman had. But just remember, you haven't excluded a diagnosis with a normal TSH. So in this guy's case, the free T4 is obtained and it is very low. So his diagnosis is central or secondary hypothyroidism. So when this happens, your next step is going to be to check pituitary function labs, get a pituitary MRI, that kind of thing. All right, so now let's move on to something, excuse me. Something that we see quite a lot of. Here's a 50-year-old surgeon. She's a triathlete. She has primary hypothyroidism and she's been treated for years with levothyroxine. But, she's a very credible patient. And, she's not a whining patient. She's very credible, but she feels terrible. She still has fatigue and depression, even though her TSH and her free T4 are normal. So the question that comes up a lot is there anything else you can do for this patient? And if I have a patient like this who is accomplished and credible and not particularly whiny, I think this is the time that we can think about adding T3 to their regimen. Now, if I have a patient that has a long history of complaining about everything and doesn't tolerate anything, I'm not going to think about adding T3 to that person. If it's someone that I really doubt that that's going to help them very much, but increasingly we're starting to consider adding T3. So here's a little bit of background in the controversy. So in a normal thyroid, the thyroid produces both T4 and T3. T4 is the most plentiful hormone, but T3 is the active one. So in the tissues, T4 is converted to T3. Now, there's a different enzyme, there are deiodinases that convert this T4 to T3. There's different deiodinases in lots of different tissues. And so, there's some possibility that this conversion may be inadequate in some patients. And so people have proposed, and there's a lot of research on this, so there is biological plausibility for this, that even though their blood levels of T4 are okay, perhaps their brain levels, their blood levels of T3, what's believed is that T4 is converted to T3 as you need it. And it's possible that in some tissues like the brain, that is not being converted appropriately. So that's the consideration. Now we know that levothyroxine has no T3 in it, and we know that patients on levothyroxine alone have higher than what's considered normal T4 to T3 ratios. So if you look at the recommendations from the American Thyroid Association and the Endocrine Society and the American Association of Clinical Endocrinologists, everybody agrees that routine use of T4 plus T3 in patients who are unhappy with T4 alone, it's not recommended from a routine basis. Because there's been a lot of studies on this and they usually don't show any benefit. However, some studies have shown a possibility of some benefit. And certainly a lot of patients are reporting improved quality of life when you add T3. So here's just like a study where people who had T3 added to their regimen of T4, in 7 out of 8 tests of mood, they were better with T3. And here's another trial where about a half of the people preferred the T4-T3 combo to T4 alone. So, there's some studies that suggest there may be some kind of an improvement. So what a lot of experts now are recommending is that a trial of T3 plus T4 in a ratio that attempts to mimic normal physiology. That's a ratio of about 13 to 60 to 1 of T4 to T3, while maintaining a normal TSH. It's reasonable in selected patients. So if I have a credible patient that's just not feeling right, I think it's reasonable to give them a little T3 and see if that makes them feel better. But it's important that when you give them the T3, you have to back off on the T4 so their TSH is not suppressed. You do not want to make the person hyperthyroid. It's not recommended that you try this with people who are pregnant or older, have underlying cardiovascular disease or osteoporosis because of a risk of over replacement with thyroid hormone on this regimen. And this is straight out of UpToDate. If you decide that you would like to add T3 to the T4 regimen, you need to reduce the dose of T4. So if you're having somebody that's like on 100 micrograms a day of levothyroxine, you might want to reduce that to around 75, and then add T3 at this low dose, 2.5 micrograms twice a week. And there's other regimens that you can try here. I mean, I'm sorry, not twice a week, twice daily. What I usually do is add the levothyroxine twice a day. Some people will add it 3 times a day. But it's important to keep this ratio of this 13 or 16 to 1. And a lot of times patients are coming in with desiccated thyroid extract. That's like the Armour or that NP thyroid. And it has a ratio of T4 to T3 that's 4 to 1. So it's not recommended. It's pretty hard when you're giving people desiccated thyroid, they have these relatively high T3 levels, and that suppresses the TSH. And there's a concern that that is going to increase the risk of osteoporosis and tachyarrhythmias. So it's really advised to not give them that heavy dose of the T3. So I just add T3 liothyronine. I just add that. I don't give them these combos. The other problem with these combos with the Armour or the NP thyroid is it's a gamish of thyroid hormones, and you don't really know, how much is T4 and how much is T3, and it can vary from batch to batch and from pharmacy to pharmacy. So it's kind of hard to adjust this to keep the TSH in the normal range. So I'll tell you what I do is if a patient comes in on Armour or NP thyroid, Nature thyroid, I say, hey, ma'am, I'm going to check your TSH. If it's normal, you can stay on it. But if the TSH is not normal on one of these combinations, I won't adjust it. I will really insist that they switch over to a combination of levothyroxine plus liothyronine. But want to reiterate though, I don't normally offer T3. My practice is to treat with levothyroxine alone, but I do consider T3 if a patient isn't feeling well. All right, so let's move along to a different type of case. Here's a 65-year-old woman who feels terrific, and on just routine screening, her TSH is slightly elevated at 6.8, and her free T4 is 1.0. And so, a couple things come up with this slide. You could say, well, why do we screen her? Well, I think hypothyroidism is so common. Primary hypothyroidism is so common, especially as people get older, that I think it's fair to screen everyone. I pretty much restrict my screening to people who maybe have some symptoms of hypothyroidism or some signs, including hypercholesterolemia or high blood pressure. It's not hard to find a consequence of hypothyroidism. So I end up screening a lot of people. So you find someone here that's got this slightly high TSH with a normal free T4. So what should your next step be? Well, what I would do is I would just repeat these labs in 6 to 12 months. And we'll talk about this in the next couple slides, but what I would propose is this is just age-specific normal. We know that TSH levels go up a little bit with age, and anything up to around 7 or 8 is probably normal for a 65-year-old. So I wouldn't do anything except just keep my eye on the labs. So she's got this subclinical hypothyroidism by definition, and all that means is subclinical hypothyroidism means it's a high TSH with a normal free T4. In itself, this isn't a problem. The only reason we kind of think about it is we worry that it may progress to become a problem. And so if you're worried that this is going to progress and become a problem for the patient, then you can consider treating it. So as I mentioned, normal TSH increases with age. Up to around 8 is considered normal in older patients. And we do know from a lot of trials that there is no clear benefit of treating people with subclinical hypothyroidism. So if you're going to treat them, you should know why you're treating them. You're treating them so it doesn't get worse with time and they don't feel bad. You should not expect to treat subclinical hypothyroidism and have the patient feel better. And we certainly know there are risks of overtreatment. We worry about bone fracture, AFib, cardiovascular events if someone is overtreated, and it's easy to overtreat somebody. We do know that if you have subclinical hypothyroidism, about 2 to 4% of patients per year are going to progress to overt hypothyroidism. And that occurs especially with these TSHs over around 10 to 14. And or if they have positive anti-TPO antibodies. So probably a lot of y'all have heard or were taught or just your practice that you treat a TSH over 10. And the reason for that is that if the TSH makes it to 10, there's a pretty good chance that it's going to go on up and be 11 and 12 and 15 and 50. So you're treating it because you just want to nip it in the bud before it becomes a problem. Now, I don't typically check TPO antibodies, but if you have a patient that's kind of on the fence and they don't know if they want to be treated or not, and they have a TSH of, 10, and they feel fine, it might be fair to say, hey, let's just check some antibodies, and if they're positive, let's treat your TSH of 9 or 11, and if they're negative, we'll just continue to follow it. So those are some considerations there. So here's a trial that was a meta-analysis of treatment of subclinical hypothyroidism. They were randomized controlled trials were included in the meta-analysis, 11 studies, around 2,000 non-pregnant patients. The average TSH after the intervention, this was just to treat with levothyroxine. It was TSH was in the normal range, where the controls were up to around 15. And there were absolutely no benefits for depressive symptoms, fatigue, tiredness, cognitive function, muscle strength, blood pressure, or BMI. So I know that we want these things to get better with thyroid hormone replacement, but they just don't in this trial. Here's another trial that focused on older patients with subclinical hypothyroidism. They were treated with thyroid hormone versus placebo, around 700 of them, followed for a year. And once again, no benefits on any of the symptoms or quality of life. Now that's whether or not you looked at the whole group, but they also, in that trial, they came back a few years later and they pulled out a subgroup that had very severe symptoms. So they had subclinical hypothyroidism and symptoms that sounded like hypothyroidism, but they didn't have any benefits of treatment either. So I know a lot of times we think, well, it's subclinical hypothyroidism, but they feel bad, so I'm going to give them some medication and see if they get better. Well, I'm not going to say you shouldn't do that. I'm not saying that will hurt as long as you don't over replace them and make them hyperthyroid. It's not going to hurt them probably, but it may be a medication that they don't need and is not, and I wouldn't do that and expect them to feel better. On the other hand, if you have a person who could get into trouble if they developed hypothyroidism, you go ahead and treat them. And the classic case of that is a woman with reproductive potential who has subclinical hypothyroidism. And there's a few things just to sort of know about this. We know that TSHs more than 2.5 may be associated with miscarriages and difficulty conceiving. So normal ranges of most assays go up to about 5, but if you've got a patient that's having miscarriages or they're having trouble getting pregnant and they want to get pregnant, most of us would just now drive that TSH down into less than 2.5. So no one recommends that you take every woman that wants to get pregnant and put their TSH less than 2.5. But if there's a person who's having some trouble, it would be a reasonable things to do. We also know that hypothyroidism is associated with high risks to the fetus for cognitive impairment, especially if it's present in the first trimester. And we know that thyroid hormone requirements increase during pregnancy. So what you don't want to have happen is you don't want to have someone who has hypothyroidism, subclinical hypothyroidism. They're kind of compensated. They get pregnant. Their thyroid hormone requirements go up. They need more, but they can't make more because they were making all they could. They had subclinical hypothyroidism. And then that baby is exposed to hypothyroidism in the first trimester, and that could be very dangerous for the baby. We know that it's early on, in the first trimester, the increase in the thyroid hormone requirement is about 30 to 40%. And so what's recommended is if the patients got subclinical hypothyroidism and they're not already on levothyroxine, you can initiate treatment if it's possible, if they're going to get pregnant. And I always think, since half of pregnancies are not planned, that anybody that's not on birth control and is reproductive age could get pregnant. So I treat subclinical hypothyroidism in this population. If the patient is already on levothyroxine, this is something that we sometimes forget to do, but we should do. You tell the patients to take 2 extra pills a week as soon as they know they're pregnant. So patients that I come in, they're feeling great, they're well, but they're a young woman that just happens to be taking levothyroxine. She should know that the minute she becomes pregnant, she needs to contact you, and you want to check labs to make sure that her thyroid function is appropriate during her pregnancy. But you don't want her to wait around to see you to get more thyroid hormone on board, because this first trimester is so important. So I just tell the patients, hey, take 2 extra pills a week. So maybe starting on a Monday and a Friday. So you find out you're pregnant on Monday, take 1 extra pill, whatever you're taking. Take it then, and then take it in a few days, and then see me as soon as you can. To sort of summarize, for subclinical hypothyroidism, we avoid treating older patients. We consider treating people with reproductive potential, and you consider treating if TSH is greater than 10. Shown here in a picture, reproductive potential, treat. If they don't have reproductive potential, treat for TSH is over 10. If their TSH is up to around 8, and they're older, more than 70, 65, 70, that's appropriate for age. So all you can do is just keep your eye on this. Check the lab again in 6 months if that makes you feel better, to just convince yourself that it's stable. If it's been like that for a while, just let it go. It's that's normal for age. If the TSH is up to about 8 and they're a little younger, then you can look and see if they have a goiter, or you can check antibodies and consider treating if those are positive. At numbers in between them, also you can consider, like I mentioned, with subclinical hypothyroidism, if they've got a goiter or positive antibodies, you might consider treating. All right, so we were talking about hypothyroidism. Let's now switch over to hyperthyroidism. So here's a woman with weakness and nervousness for about 3 weeks. Short period of time, 3 weeks. She's also noted occasional palpitations and tremor and a few pound weight loss with a normal appetite. She looks healthy. Her heart rate's 88, mild eyelid retraction and hand tremor, no thyroid enlargement or nodules. Her TSH is low at 0.04, and her free T4 is high. So this patient has hyperthyroidism. TSH is low, free T4 is high. So what does anybody want to do with her? Well, what I would do is I would repeat those TFTs and a TSI in 4 to 8 weeks. So let's just sort of go through why I'm doing that. When I see someone who has hyperthyroidism, I say, okay, why do they have hyperthyroidism? And there are 3 main common causes for hyperthyroidism. They can have thyroiditis, which I mentioned, that's a transient condition. Most of them end up having Graves' disease, or they can have a toxic nodule. Now, all of those are going to be managed a little differently, so you want to know what's causing the hyperthyroidism before you decide about further evaluation and treatment. So this could be thyroiditis because it's only 3 weeks and she's got pretty mild symptoms. And so it's not going to hurt her to just repeat those TFTs in a couple months and see what happens. Since we know that the hyperthyroid phase of thyroiditis only lasts a couple months, if you repeat labs in a couple months, the TSH and the free T4 should be changing by then. And so they should be normalizing. And so you'll have an answer, or you can exclude thyroiditis just based on repeat labs. Now, you could also do a thyroid scan and uptake, but if I could send a patient for repeat labs, that's a lot easier than sending them for a scan and uptake. The next thing would be Graves. So we check thyroid stimulating immunoglobulins, and that's why when I brought this person back, I would just go ahead and check at the same time. If they're positive, that's very sensitive and specific for Graves. She's got Graves disease if those things are positive. And so I would just check them at the same time. Now, once again, we could also send her for a thyroid scan and uptake, but that's just a lot of trouble to, send someone for that test. She has to go, she has to take out some iodine, she has to come back in 24 hours, let's take an x-ray. That's just a lot of trouble when you can just check a blood test in a couple months. And finally, toxic nodules is a possibility. And so the only way you're going to be able to diagnose this is going to be with a scan. And you may end up doing this. And certainly if someone's hyperthyroid and you palpate a nodule, sure, you're going to, the next step I would do would be the scan and uptake if you think that may be a hot nodule. But for most patients, you bring them back in a couple months for these mild conditions and you're going to have your diagnosis. This is just a picture of the triphasic effect of thyroiditis. Remember, you have some kind of an insult, whether it's virus, postpartum, something unknown. People have a spilling out of preformed thyroid hormones. So they're hyperthyroid for a couple months. And then it's a damaged gland that doesn't make thyroid hormone anymore. So levels start to fall and they can actually go into the hypothyroid phase before they normalize on their own. No treatment is needed for this. You just wait it out. Sometimes if they're really symptomatic, you might give them a beta blocker during the hyperthyroid phase, but usually you don't need treatment. And likewise, I've heard people have actually given short courses of levothyroxine during the hypothyroid phase, but I don't think I've ever done that. So this just sort of runs through the management of thyroiditis. It presents typically with relatively mild symptoms, around 2 to 6 weeks of symptoms. It may be a painful thyroid and commonly occurs after a pregnancy or recent URI. You don't have to have any of those. We don't have etiologies for the thyroiditis in most patients. For diagnosis, you just repeat the labs. Now you can get, like I mentioned, that scan and uptake, but you can't just wait it out and it'll declare itself. Treatment resolves on its own. So here's another little algorithm for this. So if you have someone that has persistent, this is after, at least 6 or 8 weeks of hyperthyroidism, not if they've had hyperthyroidism for a week, but if they've had about, a couple months of symptoms, your first question is, can you palpate nodules? If the answer is yes, well, get a scan and uptake. You want to know if this is a hot nodule or not, because you're going to treat that differently. And that scan and uptake will tell you if it's thyroiditis, Graves, or toxic nodule, bam, you're done. But if you don't palpate nodules on exam, then the next thing I would do is I'd get the TRAbs or the TSI antibodies. If they're positive, your diagnosis is Graves. You got your diagnosis. Now you can decide how you want to treat. You're done. If it's negative, you're going to have to go ahead and do that scan and uptake to get a etiology. This is what the scans and uptakes look like. The first one, A, is just normal diffuse bilateral uptake. And take a look at this. this pattern because it kind of matters when you're starting to talk about prognosis after treatment with radioactive iodine. For B, this is Graves. It's intense, increased bilateral homogeneous uptake. So this is the iodine goes to the whole gland. So if we choose radioactive iodine ablation for this gland, it's all going to be wiped out and the patient will probably be hypothyroid for the rest of their life. Versus if it's a toxic multinodular goiter shown in C, or a single toxic nodule shown in D, if you give that person radioactive iodine here in the toxic nodule, it's all going to go to the nodule. The rest of the gland will wake up and the person could be euthyroid for the rest of their life. So a lot of us would prefer to treat toxic nodules with radioactive iodine because they'll be euthyroid for the rest of their lives. And so that's kind of the preferred initial treatment. Whereas Graves, since you're going to probably make them hypothyroid, we often choose to just sort of wait it out and see if Graves will get better on its own so we don't make them hypothyroid. Now, if you took someone with a thyroiditis, you can see here there's no uptake. The thyroid doesn't show up. That's because it's a damaged gland. It spilled out the preformed thyroid hormone. That's why they're hyperthyroid for a while, but it's a damaged gland. It doesn't take up iodine, so it's nothing. So nobody would give this patient radioactive iodine and it wouldn't do anything if you did, because it's not going to go into the thyroid. So for management of Graves' disease, you could, maybe they'll have some symptoms or signs that make you know it's Graves. They could have proptosis, pretibial myxedemia, or they could have a diffusely enlarged thyroid with a bruit or thrill. If they have any of these, you've got a diagnosis. You don't need anything else. Proptosis, pretibial myxedema, bruits and thrills, those are pathognomonic for Graves. It's a hyperactive gland, and these are the extrathyroidal manifestations of Graves. You don't need anything else. That's Graves. Usually they don't have all that stuff, so your diagnosis is going to be with the antibodies or the scan and uptake. Now, Graves can go into remission. After 2 to 5 years, about a third to a half of the patients will go into remission. So if you think they're going to go into remission, you might want to just wait it out and see if they'll go into remission rather than treat them with radioactive iodine. If you treat them with radioactive iodine, they're going to be hypothyroid for life. So a lot of times we just give them methimazole, just sort of wait and hope that they'll go into remission. Surgery is also a possibility, but we just rarely do that because surgery is surgery, and there's complications associated with that. Toxic nodules, on the other hand, they present as nodules. You can diagnose them with the scan and uptake. They do not typically go into remission. We rarely do surgery. You could do methimazole, just like with Graves' disease, but you kind of need to do this on an ongoing basis and monitor. Whereas if you're giving someone levothyroxine, you can just check their labs once a year and they should be fine. With methimazole, things can change, so I usually do check every 3 months while people are on methimazole. And what's important to note, though, that if you give them radioactive iodine, they could be euthyroid after treatment and not need anything. So these are sort of a summary of the options. Thyroiditis, it's going to go into resolution spontaneously. You don't use methimazole, you don't do radioactive iodine, and you don't do surgery. You just wait it out. Graves' disease, 30 to 50% of people go into remission at 2 to 3 years. So normally I give them methimazole and sort of hope for them to go into remission. And if they do, we're done. If I give them radioactive iodine, they're likely going to be hypothyroid. And surgery really is reserved for special situations, such as uncontrolled hyperthyroidism in pregnancy. We don't, fortunately, have to deal with that very often. And then finally, we have the toxic nodules. They don't typically go into remission. We generally can treat them with methimazole, but since they're going to be euthyroid after radioactive iodine ablation, you might try that first. That could be an early thing. All right, so those, we were talking about overt hyperthyroidism. Now let's talk a little bit about subclinical hyperthyroidism. The TSH is undetectable, the free T4 is in the normal range, the T3 is normal. These labs have been present in this 70-year-old for the last several years, for 3 years. So she's got persistent subclinical hyperthyroidism with an undetectable TSH. What do you want to do with her? I am going to say that we should either start her on methimazole right away or send her for a thyroid scan and uptake and see if you want to treat with radioactive iodine. Whereas subclinical hypothyroidism doesn't cause any problems and you just don't want it to progress. Subclinical hyperthyroidism can be associated with complications such as osteoporosis, atrial fibrillation, and cardiac events. And when the TSH is undetectable like this, especially in an older person, that's associated with increased mortality. So we generally go ahead and treat those hormones. Subclinical hyperthyroidism, low TSH, normal free T4. Now the data aren't perfect, and this slide just sort of shows you a summary of some of the data. It's a complicated slide, but just to walk through it, this first column we're going to look at looks at the strength of association. So there's pretty good data that a low TSH is associated with atrial fibrillation, progression to overt hyperthyroidism, and reduced bone mineral density in postmenopausal women. Pretty good data that happens. And if you look at treatment, they're pretty, there's some evidence, limited quality, but there's some evidence that treating subclinical hyperthyroidism will improve heart failure and other cardiovascular events, as well as improve bone density. So there's some evidence for that. So these aren't perfect randomized controlled trials, but so the recommendations around subclinical hyperthyroidism in older people especially come from consensus expert opinion. So basically, if they have subclinical hyperthyroidism, you look and you see, are they at risk for complications? So do they have osteoporosis, AFib, heart disease, or they're older? If the answer is no, you can watch them if the TSH is detectable but low. You can keep your eye on them for a while. If it's very low, you can observe or go ahead and treat them. If they're older, though, they have these risk factors. Most people would go ahead and treat the very low TSHs or just keep their eyes on the ones that are a little bit higher. This slide is just as a reminder that TSH targets vary. Most adults, you want their TSHs to be in the normal range. Older adults, you want them to be slightly above normal. Actually, mortality data are better for older people with the TSHs closer to 8 than to 0.6. So you want them in the normal range, but a little bit high is okay. Women with miscarriage or trouble conceiving, you're going to have a low normal range, like between 0.5 and 2.5. And then also, if there someone has had a thyroidectomy for cancer, then depending on how high risk the cancer is, you may have a completely suppressed TSH may be their goal, or it may just be the lower end of the normal range. So just remember, your targets are going to vary depending on the clinical situation. So always be aware when someone's, presenting with this situation that you know what your goal is going to be for that person. I want to finish up real quickly with thyroid nodules. So here's a man who presents with a thyroid nodule on physical exam. You ask, what is your next step? Well, I would just check a TSH. I don't need any of these other tests right now. They don't help us. Not indicated. You don't need to get a scan, antibodies, free T4, CT. You don't need any of these things. Just start with the TSH. The reason you want that TSH is the higher the TSH, the higher the chance of malignancy. So if you have a TSH that's elevated, in this particular study, about a 30% chance of malignancy, where it's very low chance of malignancy if it's a TSH is low in a hyperthyroid range. So you want to check the TSH. That's the first thing you want to know. So that you'll know whether or not you need to do an FNA or not. So if they've got a low TSH, then they may be hyperthyroid. So this could be a functioning nodule, it could be a hot nodule. And in those cases, so if someone has a nodule, TSH is low, I get a scan and an uptake. If it's a hot nodule, it's very unlikely to be cancer and we don't want to biopsy it. We also don't want to biopsy a hot nodule because it gives false positives. Those metabolic cells can look like cancer cells, so we don't biopsy hot nodules. But we could consider for radioactive iodine ablation. If it's a normal or a high TSH, then we're just going to look and see if we want to biopsy it. And then we need to get that ultrasound to see if it meets criteria for sampling. And basically, the more high-risk features they have, the lower threshold you have to do a biopsy. So if they have no high-risk features, you don't need to do a biopsy because it's very unlikely to be cancer. But if they have 3 high-risk features shown here is microcalcifications, solid, and size over 2 centimeters. If they have all 3 of those, it's almost certainly going to be cancer. And, if they have a couple of those, it's a higher risk and so on. So this is just outlines the American Thyroid Association recommendations on which nodules to biopsy. So basically, if it's less than a centimeter, you almost never biopsy, only in very rare situations, like if you're looking for a metastasis, something like that. So usually you don't biopsy less than a centimeter. And if it's a pure cyst, you're not going to biopsy that either. Cysts are kind of considered protective, if you want to think of it like that. So you're looking at the solid or partially solid nodule. So if it's solid with a suspicious feature, you biopsy over a centimeter. Solid, no suspicious features, you can biopsy at 1.5. And if it's partially cystic, thinking of cysts as being a little protective and no other suspicious features, you can biopsy at 2. A lot of radiologists these days use these TRAD classification where they assign points and they tell you on the report whether or not it needs a biopsy or not. Basically, the more high-risk features, the lower your threshold for biopsy. So this summarizes the approach to nodules. They've got a thyroid nodule on exam or imaging, check a TSH. If it's normal or if it's high, you're just going to get an ultrasound to assess the need for an FNA. Now, sometimes you didn't palpate that on exam. You found out about it because it was an incidentalloma. So it wasn't an exam, it was a CT scan that was done to look at their back pain or something. But you're going to treat it the same way, whether it showed up as an incidentalloma on imaging or you palpated it on your exam. So then you're going to look at these ultrasound characteristics, see if you need to biopsy, if it meets criteria, biopsy it. If it doesn't, then you can repeat an ultrasound depending on how high risk it looks in 6 to 12 months, and then you can spread out the frequency of surveillance with the ultrasound, maybe every couple of years, maybe every 3 to 5 years. We don't have great evidence to guide us, so the frequency of follow-up is just depending, it's just expert opinion, and basically the lower the risk, if it just doesn't look that bad and it's been stable for a while, you can spread out the frequency of monitoring. But this is why we don't want people to get ultrasounds on people that are probably not having cancer. That would be someone with just abnormal thyroid function tests, because you're going to get stuck with all of these ultrasounds for the rest of their lives and maybe unnecessary biopsies. So if the TSH is low, then you're going to need to get that scan to evaluate the nodule. If it's cold, just you move over to this side and see if it get an ultrasound and see if it meets criteria for FNA. If it's hot, you'll think about maybe radioactive iodine ablation. And that's what I have. And if anybody has any questions, I think we have a few minutes.
Thank you so much, Dr. Pendergrass. That was fantastic. I don't see any questions yet in the chat, but we'll pause and wait. While I'm stalling, you can put them into the Q&A box, the chat box, or use the raise hand feature. I will give you a quick reminder about the CME survey to use the correct date and speaker. So October 8th, Dr. Merri Pendergrass, and you'll get your CME certificate almost immediately. And if you think of a question after the fact, I'm notorious for doing that. You can always submit them into our Q&A box. Nope, not our Q&A box. That would be for this session. You can always submit an e-consult on our community portal to Dr. Pendergrass or to any of our MAVEN Project volunteers. So I don't see any questions. I think we'll pause it here, then we'll stop it here then. Dr. Pendergrass, thank you so much for a fantastic presentation. Thank you, Rosie, for being around, and thank you for everybody for joining us today.
Have a great day, everybody.